Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 351 of our pharmacotherapy series, which majors in asthma. The first case reads, QCI, a 6-year-old, 20-kilogram girl, presents to the accident and emergency department with complaints of dyspnea and coughing that have progressively worsened during the past 2 days. These symptoms were preceded by 3 days of symptoms of a viral upper respiratory tract infection, sore throat, rhinorrhea, and coughing. She has experienced several bouts of bronchitis in the last 2 years and was hospitalized for pneumonia 3 months ago. QCI is not being treated with any medications at present. Physical examination reveals an anxious-appearing young girl in moderate respiratory distress with audible expiratory wheezes, occasional coughing, a prolonged expiratory phase, a hyperinflated chest, and suprasternal, supraclavicular, and intercostal retractions. Bilateral inspiratory and expiratory wheezes with decreased breath sounds on the left side are heard on auscultation. QCI's vital signs are as follows. She has a respiratory rate of 30 breaths per minute, a blood pressure of 110 systolic 83 diastolic, a heart rate of 130 beats per minute, a body temperature of 37.8 degrees Celsius, and pulsus paradoxus, 18 mm of mercury. Her arterial oxygen saturation, abbreviated as SaO2, by pulse oximetry is 90%. QCI is given oxygen to maintain arterial oxygen saturation greater than 90% and 2.5 mg of albuterol by nebulizer every 20 minutes for 3 doses. After the initial treatment, QCI claims some subjective improvement and appears to be more comfortable. However, wheezing on auscultation becomes louder. So my question to you is, what signs and symptoms in QCI are consistent with acute bronchial obstruction? Does increased wheezing after albuterol indicate failure of the medication? Asthma is an obstructive lung disease. Therefore, the primary limitation to airflow occurs during expiration. This outflow obstruction leads to the classic findings of dyspnea, expiratory wheezes, and a prolonged expiratory phase during the ventilatory cycle. Wheezing is a whistling sound produced by turbulent airflow through a constricted opening and usually is more prominent on expiration. Thus, the audible expiratory wheezing in QCI is compatible with bronchial obstruction. In fact, QCI's obstruction is so severe that even inspiratory wheezes and decreased air movement were detected on auscultation. It is important to realize that the classic symptom of wheezing requires turbulent airflow. Therefore, Effective therapy of acute asthma actually may result in increased wheezing initially because airflow increases throughout the lung. As a result, QCI's increased wheezing on auscultation is compatible with her clinical improvement after the albuterol nebulizer treatments. The coughing experienced by QCI is another common finding associated with acute asthma attacks. The coughing may be caused by stimulation of irritant receptors in the bronchi by the chemical mediators of inflammation, e.g., leukotrienes, that are released from mast cells or from the mechanics of smooth muscle contraction. In the progression of an asthma attack, the small airways become completely occluded during expiration, and air can be trapped behind the occlusion. Therefore, the patient has to breathe at higher than normal lung volumes. Consequently, the thoracic cavity becomes hyperexpanded, and the diaphragm is lowered. As a result, the patient must use the accessory muscles of respiration to expand the chest wall. QCI's hyperinflated chest and her use of suprasternal, supraclavicular, and intercostal muscles to assist in breathing also are compatible with obstructive airway diseases. Occlusion of the small airways, air trapping, and resorption of air distal to the obstruction can lead to atelectasis, incomplete expansion or collapse of pulmonary alveoli or of a segment of a lobe of the lung. Localized areas of atelectasis often are difficult to distinguish from infiltrates on a chest radiograph, and atelectasis can be mistaken for pneumonia. QCI's history of multiple bouts of bronchitis is significant and typical of many young asthmatic patients. In any patient with recurring episodes of bronchial symptoms, i.e., bronchitis, pneumonia, the possible diagnosis of asthma should be investigated. The increased pulse, respiratory rate, and anxiety experienced by QCI can be attributed to both the hypoxemia and the feeling of suffocation. The hypoxemia in acute asthma is caused principally by an imbalance between alveolar ventilation and pulmonary capillary blood flow, also known as ventilation-perfusion mismatching. Each alveolus of the lung is supplied with capillaries from the pulmonary artery for gas exchange. When ventilation is decreased through an area of the lung, the alveoli in that area become hypoxic, and the pulmonary artery to that region constricts as a normal physiologic response. As a result, blood flow is shunted to the well-ventilated portions of the lung because of the need to preserve adequate oxygenation of the blood. The pulmonary arteries, however, are not constricted completely, and when a small amount of blood flows to the poorly ventilated alveoli, mismatching is the result. Conditions of diffuse bronchial obstruction, i.e., acute asthma, increase the amount of mismatching. In addition, some mediators of acute bronchospasm, e.g., histamine, further worsen mismatching by constricting bronchial smooth muscle while concurrently relaxing vascular smooth muscle. QCI also demonstrated a significant pulsus paradoxus. Pulsus paradoxus is defined as a drop in systolic BP of more than 10 mm of mercury with inspiration. In general, pulsus paradoxus correlates with the severity of bronchial obstruction. However, it is not always present. My next question to you reads, what additional tests would be helpful in assessing the extent of pulmonary obstruction in QCI? Chest radiographs are not recommended routinely, but should be obtained in patients who are suspected of having a complication, e.g., pneumonia. Hyperinflated lungs and areas of atelectasis can be seen on a chest X-ray film. However, chest X-ray studies usually are negative and of little value in evaluating acute asthma attacks. The finding of a local decrease in breath sounds in QCI's left lung may justify the need for a chest X-ray study, particularly if a significant differential in air movement persists after initial therapy. A local decrease in breath sounds may indicate pneumonia, aspiration of a foreign object, pneumothorax, or merely thickened mucus plugging of a large bronchus. Pulmonary function testing, e.g., forced expiratory volume in 1 second abbreviated as FEV1 and peak expiratory flow abbreviated as PEF, provides objective measurement of the degree of airway obstruction. Peak flow meters are helpful in the emergency department for assessing both the severity of airway obstruction and the response to bronchodilator therapy. Unfortunately, infants and many young children do not have the cognitive or motor skills necessary to perform pulmonary function tests. EPR3 points out that in one study only 65% of children 5 to 16 years of age could complete either forced expiratory volume in 1 second or peak expiratory flow during an acute exacerbation. Because of QCI's initial anxiety, the peak expiratory flow should be measured after bronchodilator therapy has been initiated when she may be calmer. One disadvantage of pulmonary function tests in acute asthma is that the forced expiratory maneuver commonly triggers coughing. ABG measurements are the gold standard for assessing very severe airway obstruction. EPR3 suggests ABGs for evaluation of PaCO2 in patients who have suspected hypoventilation, severe distress, or forced expiratory volume in 1 second or peak expiratory flow less than 25% of predicted after initial treatment. ABG measurements are indicated in patients who fail to respond adequately to initial therapy or in patients requiring hospitalization. They are not indicated at this time for QCI. A repeat pulse oximetry at 1 hour after treatment initiation is warranted in QCI to ensure adequate arterial oxygen saturation. QCI may require hospitalization. So my next question to you in connection with this is, which clinical test is predictive of the need for admission or whether QCI will relapse if sent home from the accident and emergency department? Are QCI's signs and symptoms predictive of whether she will relapse and return to the accident and emergency department if not hospitalized? The most useful predictive tool is the forced expiratory volume in 1 second or peak expiratory flow response to initial treatment. Patients who do not improve to at least 40% of predicted forced expiratory volume in 1 second or peak expiratory flow after initial intensive therapy are more likely to require hospitalization. Although QCI is not able to perform spirometry, she is able to execute the peak expiratory flow maneuver, and the plan is to check her peak expiratory flow after 1 hour of therapy. Signs and symptom scores alone are not adequate to predict outcome of accident and emergency department treatment of asthma, but scores along with pulse oximetry and peak expiratory flow or forced expiratory volume in 1 second are helpful predictors. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 352.